Again, thank you for inviting me to participate in this. It's nice to see my classmates over the internet. As mentioned, asthma is one of those diseases that I've been quite interested in my pulmonary career. Actually, it's very interesting how over the years the treatment for asthma has changed significantly. But you know, with all the new changes with asthma medications, I think going back to basics is still a very useful and how would you call it? It's a very useful and fruitful endeavor. So basically, as Grace had mentioned, when the use of the guidelines for stepwise therapy is very important because determining where you are in terms of the disease process will determine the proper treatment that you will provide. So evaluation is very important. And really, if going through the guidelines, you really don't need any important, well, you don't need any advanced machines. All you really need is to get a decent history, a good stethoscope, and if you have a spirometer, well, at least a spirometer and a peak flow meter, you should be able to provide a very decent therapy to 90% of people. I also agree with Grace in terms of the use of a spacer. I think I would expand that to say that depending on the situation where you are, not only is it the technique that's important, I guess it's the method of delivery for inhalers that would be also very important. I guess creativity also can come into play in certain situations. I remember that when we were doctors in Sorsogon many eons ago, we tried to make our own spacers using soda bottles. You know, you can be creative with using everyday materials so that you can improve the delivery of the medications that are in inhalers. Because as a standalone inhaler is really a very poor delivery device, and a spacer will improve the delivery of the medications by about 50 to 60% if done properly. Grace had asked me about the use of spirometry as a measure for lung function. I don't do any pediatric, in terms of the pediatric population, I do not do too much test. Well, I don't do testing for pediatrics. Most of my experience is really in adults. But in terms of spirometry, I think spirometry is a very useful tool. It's actually a very useful tool for both determining the presence of reversible airway disease and for identification of people with beginning obstructive disease. So basically, as Grace had mentioned, the FEV1 to FVC ratio is the parameter that they use for children. We also use that in adults, but the value that we use is lower. But the use of the spirometer, the use of spirometry for identifying people with possible airway disease is, I think, the minimum that you should have in terms of so that you can really identify these people. The other caveat that I would add is if you are able to how would you say it? If you are in an institution that does have more advanced equipment, I was wondering how effective, and I'm posing this question to Grace, if they have any information about the use of plethysmography, where you are using plethysmography to measure airway resistance and conductance and specific conductance to identify patients. Because specifically in my experience, I think the maneuvers for plethysmography is less dependent on effort as compared to spirometry. So that's just just a caveat. But then, you know, that to be able to do plethysmography, you have to have a body box.
Yeah, can you,
Go ahead.
well, to that point, we were able to use the body box plethysmography during fellowship. So it was at a tertiary center at a big city. It was a referral center, but and again in Virginia. So I think even if it's a useful tool or an important tool, access to a body box apparatus would be a very crucial issue. So you still would probably have to refer the patients to a bigger hospital center where a pulmonologist would be able to interpret the results. And it has limited use in children.
Oh, yeah, because that was my question. Because my experience with, and this is more my experience and with talking to respiratory therapists, in doing the maneuvers for plethysmography, it's less effort dependent. So I don't know if there are studies to show that, at least in the pediatric population, because in adults sometimes since we have plethysmography, I would refer and sometimes depend more on the plethysmography compared
Than spirometry.
than spirometry, especially if effort was in question. So it's just, you know.
Yeah, I don't know about that. I think it's more accessible for me because you could have an office spirometer, and so you use that at
Right.
point of care
Right.
versus having to schedule a patient for body box plethysmography at the tertiary hospital. So, yeah, but I see your point.
Yeah, in terms that's type of device that you're going to use to deliver the medication will be essential because you have to match it up with the patient, and I think it's just another type of it's one more tool in your toolbox that you can use, especially for people who, well, some people just prefer inhalers, some people prefer dry powder inhalers.
Or those who don't want to carry a spacer device.
Right, exactly. So I think they're using the proper technique. There's no significant difference among them. I think it might really boil down to sometimes it will boil down to the molecule, especially if you're talking about long-acting steroids and the LAMAs. So again, it's a combination of the molecule itself that you're using and the delivery system and how that delivery system interacts with your patient. So especially in kids, that will be more important too. You know, in kids, you have dry powder inhalers, you have MDIs, meter dose inhalers, and you have a nebulizer.
So they can know.
So again, just match it up with the patient.
Okay. Thanks,
Francis.
Yeah. Oh.
Yeah, because I was going to mention the thermoplasty that you were asking me about.
I didn't address that because
Yeah, in terms of bronchial thermoplasty, as a clinician here, we've been looking at that. I don't know if people are aware of what bronchial thermoplasty is. It's basically what it does is just as a preview. The theory behind it is what you use heat in the form of microwave, and you deliver the heat through probes in the airway using bronchoscopy. So basically, you do a bronchoscopic procedure. Well, actually, it's a series of 3 bronchoscopic procedures, doing one lobe, um, lower lobe, and then the 2 upper lobes in 3 different procedures. And the goal in, well, first of all, the patients that you do this in are patients who are, as of now, we were reviewing the data. I don't think the data is really out there that it is that effective. I think they've determined that it's safe. It hasn't really caused too many problems. But in terms of, I think the longest data that's available is about 5 or 6 years on people who had it done and they haven't seen any complications in them. But then in terms of the outcomes, I think the jury is still out. But basically the goal in doing bronchial thermoplasty is trying to reduce the muscle mass in the airways and to try to reduce the deposition of collagen in the airway. So just as a primer, you might be hearing more about bronchial thermoplasty, but I don't know how successful it's going to be. It's still one of those things that are up in the air. And then I guess the other things that I would mention is, you mentioned the use of leukotrienes, which, since we graduated from med school, back then our only medications were albuterol and steroid. Yeah, and theophylline. And basically, if you look at it, now you have omalizumab, which is an IgE blocker. Last month, they approved mepolizumab, which is the
IL-5.
Yeah, eosinophil. Yeah. So for IL-5.
Yeah.
And so between that, leukotriene blockers, steroids, I still use theophylline from time to time. The use of ipratropium bromide or the long-acting or the LAMAs. We've had a good amount of new medications that we can use, and depending on the medications that are available, I think we've come a long way since the days of theophylline and steroids. And I think each one has its proper use. Like I said, theophylline, what is it? You should know that. You might know this better than I do. It's theophylline is cyclic GMP and
inhibitor, yeah.
Yeah, it decreases
It has a lot of side effects.
The other one is cyclic AMP. Well, the muscarinics increase your cyclic AMP, so you have bronchodilation, and then theophylline is, or is that the other way around? And theophylline is the reducing cyclic GMP. Basically, they basically increase your bronchodilation. So we just have a lot more medications that are available now that we can use. And I guess I won't be my father's son if I don't mention. Actually, as I was listening to you, I looked up MCT oil and asthma. There's actually an interesting paper that showed that the use of MCT oil reduces your preponderance of developing allergies to peanuts, which was, they were saying that it had to do with the way the antigen was delivered to Th2. Which was, I said, oh, that's
okay.
So that's something you can do back home. Use your coconuts.
Thanks, Francis. I think I want to address one more question
Go ahead.
from Dr. Jonas Bernal. So Jonas, thank you for asking this question about when does airway remodeling start? So this is actually a very difficult question to answer because unless you do a lung biopsy and actually examine, at the cellular level, the smooth muscles and the different layers inside the airway epithelium, you won't be able to answer that question. So because it means doing lung biopsies in babies. But in fact, there were a few studies only with a small sample size that have shown that airway remodeling can actually begin as early as 24 months of age. So there is these babies who were enrolled and studied for other reasons, and their lung biopsies have shown that airway remodeling has been well on its way by that age. So I think early intervention is another buzzword that you're hearing about in asthma management circles.
Yeah, that's a very interesting question. At least for the pediatric population, I don't know how you can tell because you can't do any studies. We make it by inference when you basically have fixed airway obstruction. That's when you have airway remodeling, especially
Right.
based on the history that they've had asthma.